Ladies and gentlemen, as we commence today's meeting, I wish to use my position as chair to make some remarks. In early June, we received notification that the state intended to present the medical boards with a formal petition to initiate rulemaking on the subject of gender dysphoria, and that this petition would be presented during our August 5th board meeting in Tampa. From the onset, I directed the board staff that, given the deep sensitivities and the complexities of this issue, we approach this matter in a manner that not only was fair, but was perceived as being fair. As such, during that August 5th meeting, as we hosted our Surgeon General and others representing the position of the state, I insisted that equal time and position be granted to experts from the University of Florida, Dr. Holler and Dr. Dayton, who held an opposing position. I asked, as would Aristotle, that we approach this subject with reason, free of passion. I believe that all members present found the ensuing discussion productive, with three take-home messages. First, from oral testimony, we learned that at the major centers in Florida, so-called bottom surgery is not offered for minors, and that so-called top surgery is infrequently offered to minors, although there have been instances in Florida where females as young as 15 years old have undergone mastectomy. Second, from written testimony, we learned that there are substantive differences between the large medical societies and our European colleagues in the treatment of minors with gender dysphoria. To say that there is a singular, unquestioned standard of care is simply not accurate. And lastly, the chief point of agreement amongst all the experts, and I must emphasize this, is that there is a pressing need for additional high-quality clinical research. Subsequently, we took public comment. The selection of comments was randomized in an alternating yay-nay fashion, with the exception that I used my discretion to ensure that State Representative Anna Escamami, whom I knew stood in opposition to the petition, had a chance to speak. I did this out of respect for her office. The vast bulk of the meeting was dignified and productive, and ultimately the board voted to initiate rulemaking. The task then fell upon the Joint Rules and Legislative Committee, chaired by Dr. Zachariah, to consider and possibly develop rules language. This committee meeting was initially scheduled for September 30th, but due to the hurricane, it was rescheduled to October 28th. In preparation for that meeting, I directed the staff to invite subject matter experts with differing viewpoints and representing essentially three cohorts. The first cohort being Florida licensed pediatricians or pediatric endocrinologists who actively treat minors with gender dysphoria. The second cohort being scientists, both American and international, with expertise in the extant clinical data, and the third cohort being representatives of the large American clinical societies. Mr. Paul Vasquez, to my left, the executive director of the board, worked assiduously on this directive. We were pleased that, ultimately, representatives from the University of Florida, the University of Oxford, Yale University, University of Turku in Finland, and the Children's Hospital in Chicago, as well as a private practice endocrinologist from California, joined us at that committee meeting. A formal invitation was also extended to a large medical society known to be opposed to the state's position, namely the Endocrine Society. That society declined our invitation. Formal invitations were also sent, but declined, by physicians actively practicing at transgender care clinics at Nicholas Children's Hospital in Miami, at Johns Hopkins All Children's Hospital in St. Petersburg, and at the Joe DiMaggio Children's Hospital in Hollywood. We also received contact from several accomplished pediatric endocrinologists practicing here in Florida who stated their discomfort with the guidelines espoused by the Endocrine Society, WPATH, and the American Academy of Pediatrics. These physicians, of course, were invited to speak on October 28th, but each declined. They cited a concern that their positions in various medical societies, and indeed their actual employment, would be jeopardized should they speak. I found this culture of intimidation, be it real or perceived, to be antithetical to the spirit of medicine, and more poignantly, profoundly sad. During the October 28th Rules Committee meeting, Dr. Zachariah took additional public comment. Many of the comments, representing both the affirmative and negative positions, were emotionally powerful. To all of those who came and expressed their opinions with dignity and courage, we members of the board salute you. Further, to our subject matter experts who cited data and adduced their sources, the board also extends our thanks. This is how science should work. Vigorous debate free of intimidation. A motion by Mr. Romanello and then amended by Dr. Hunter to include a research exemption was ultimately passed. Today, the task falls upon this joint meeting of the boards of medicine and osteopathic medicine to consider the Rules Committee proposal. The proposal has the following elements. First, the rule is limited exclusively to the treatment of minors with gender dysphoria. Second, the rule is prospective. Third, once the rule is effective, sex reassignment surgery or any other procedure that alters primary or secondary sexual characteristics for the treatment of gender dysphoria in minors would be prohibited. Fourth, once the rule is effective, those minors who have already commenced puberty blocking, hormone, or hormone antagonist therapy for the treatment of gender dysphoria may be continued on hormonal therapy. Fifth, once the rule is effective, puberty blocking, hormone, and hormone antagonist therapy for the treatment of gender dysphoria in minors who have not yet commenced such therapies would be prohibited. Sixth, and very importantly, the proposal included an exception for clinical research. Specifically, non-surgical treatment for the treatment of gender dysphoria may be conducted under the auspices of an institutional review board approved, investigator-initiated clinical trial at a Florida medical school. The clinical trial must include provisions for long-term longitudinal assessment of the patient's physiologic and psychologic outcomes. Today, I stand in support of the Rules Committee resolution, as I feel that it is a thoughtful navigation between Scylla and Charybdis, as was faced by Odysseus. First, the resolution is limited only to minors. As such, the Rules Committee recognizes that our legal and medical tradition speaks to a difference in the mental capacity between minors and adults with respect to making medical decisions, some of which in this context may produce irreversible physiologic and psychologic changes. Second, the Rules Committee recognizes that surgery to alter one's sexual characteristics, including mastectomies, penectomies, and neovaginectomies, carries the highest risk of immediate, irreversible physiologic effects and ought to be approached differently than drug intervention. Third, the Rules Committee recognized that the discontinuation of hormonal intervention for patients who have already commenced such treatment would pose important complexities and therefore is not restricted. So let me be clear. Any person who opines that this resolution, if passed in its current form, would terminate ongoing care is incorrect. Fourth, and perhaps most importantly, the Rules Committee recognized, and this was made clear during testimony, that the best treatment of minors with gender dysphoria is not known. The resolution represents an effort to generally emulate what is being done by Britain's National Health Service and by others elsewhere, which is to make available non-surgical treatment, but to do so solely under the auspices of high-quality, investigator-initiated clinical trials. So, again, let me be clear. Any person who opines that this resolution, if passed in its current form, would ban access to care is incorrect. Although it may be the intent of the boards to ensure that dissemination of high-quality data on the epidemiology and the outcomes of these investigations, Board Counsel has indicated that it is not presently within our purview to mandate a data reporting requirement. Therefore, should the draft rule be adopted, I then would propose a resolution to be presented to the Speaker of the Florida House and the President of the Florida Senate. This resolution would request that the legislature pass a reporting mandate whereby each clinical trial principal investigator must transmit to the boards of medicine and osteopathic medicine an anonymized summary of the clinical data at 6-month intervals. Without a reporting requirement, investigators could elect not to share or publish data, and this would, of course, be contrary to our intent. We understand that the legislature would in no way be bound to act on such a resolution, but it is my sense that a reporting requirement is absolutely essential to a good faith research exemption. At this point, I'm going to open up the discussion to members of the two boards. Once a call to question is called, we will go and have a vote from the Board of Medicine, immediately followed by the Board of Osteopathic Medicine, and then we will proceed with public comment. If there are any publicly elected officials with us today, please make yourself known to me, as I will extend the courtesy to ensure that you have an opportunity to speak. And as far as public comment is concerned, it'll be randomized, meaning selected out of the hat, A, B, until the public comment is completed. At this point, I open the floor for discussion. Thank you very much.